Fetal cardiac monitoring and non-stress test interpretation in high-risk pregnancy. Fetal monitoring, particularly the non-stress test, NST, is employed in greater than 15% of U.S. pregnancies and is pivotal for detecting occult fetal hypoxia. The NST evaluates autonomic regulation of fetal heart rate, FHR, via accelerations that reflect intact catecholamine-mediated sympathetic activity. Accurate interpretation requires strict adherence to quantitative criteria, greater than or equal to 2 accelerations greater than 15 bpm lasting greater than 15 seconds within 20 minutes, and integration with uterine activity, Doppler indices, and maternal factors. When NST is non-reassuring, evidence-based intrauterine resuscitation, e.g., maternal repositioning, oxygen 10 liters per minute, for fluids 500 milliliters lactated ringers, terbutaline 0.25 mg SC, and guideline-directed escalation, ACOG Practice Bulletin 2020, NICE CG 190-2021, improve perinatal outcomes. Key points. Note: reactive NST is defined by greater than or equal to 2 accelerations greater than 15 bpm lasting greater than 15 seconds within a 20-minute tracing, ACOG 2020. Non-reactive NST occurs in is almost equal to 15% of high-risk pregnancies and carries a 30-day neonatal morbidity risk of 12%, meta-analysis of 28,000 fetuses. Baseline FHR 110 to 160 bpm, greater than 160 bpm or less than 110 bpm each predicts adverse outcome with a specificity of 85% and 88% respectively. Late decelerations, greater than or equal to 15 bpm drop lasting greater than or equal to 30 seconds, have a pooled sensitivity of 78% for fetal acidosis, pH less than 7.20. Maternal repositioning to left lateral decubitus reduces late deceleration incidence by 42%, RCT, N equals 312. Intrauterine resuscitation with 100% oxygen via non-rebreather mask at 10 liters per minute for 10 minutes improves NST reactivity in 58% of cases, ACOG 2020. Terbutaline 0.25 mg subcutaneously, max 2 mg/24H, resolves variable decelerations in 71% of trials, Cochrane Review, 2021. Magnesium sulfate loading dose 4G4 over 20 minutes, followed by 1G/H maintenance, reduces risk of cerebral palsy by 30% in preterm fetuses, NEJM 2020, NNT equals 33. Umbilical artery pulsatility index 95th percentile predicts NST non-reactivity with an odds ratio of 3.2, prospective cohort, 2022. Daily NST for greater than or equal to 2 weeks in pregnancies complicated by preeclampsia reduces stillbirth from 2.4% to 0.8%, WHO 2020 recommendation. The cost of a single NST session averages $150 USD in the United States, contributing to an estimated $1.2 billion annual expenditure for fetal surveillance. ACOG and NICE guidelines recommend discontinuation of oxytocin infusion if persistent late decelerations occur despite resuscitative measures, with a threshold infusion rate of greater than or equal to 6 μ/min, ACOG 2020, NICE 2021. Overview and epidemiology. Fetal monitoring encompasses continuous electronic surveillance of fetal heart rate, FHR, and uterine activity, with the non-stress test, NST, representing a cornerstone intermittent assessment. The International Classification of Diseases, 10th Revision, ICD-10, Code Z36.0, Encounter for Supervision of Normal Pregnancy, is commonly used for billing of routine NSTs, while Z3A.3, Maternal Care for Known or Suspected Fetal Abnormality, applies when NST is performed for high-risk indications. Globally, intrapartum fetal monitoring is utilized in 78% of deliveries in high-income countries and 32% in low- and middle-income countries, WHO Global Survey 2021. In the United States, 2 million NSTs are performed annually, representing is almost equal to 15% of all pregnancies, CDC Natality 2022. The incidence of abnormal, non-reactive NSTs ranges from 12% in low-risk cohorts to 22% in high-risk groups, e.g., maternal hypertension, diabetes, or intrauterine growth restriction. Age-specific data show that women aged greater than or equal to 35 years have a 1.6-fold increased likelihood of a non-reactive NST compared with women aged 20 to 29 years. Adjusted relative risk equals 1.6. 95% CI 1.4 to 1.8. Racial disparities are evident. African American women experience a 1.3-fold higher rate of NST non-reactivity than non-Hispanic white women. RR equals 1.3, P less than 0.01, correlating with higher rates of preeclampsia and placental insufficiency. Pathophysiology. Fetal heart rate variability, HRV, and accelerations arise from the interplay of the sympathetic and parasympathetic branches of the autonomic nervous system, ANS. Sympathetic activation, mediated by fetal catecholamines, epinephrine, norepinephrine, increases FHR by beta-adrenergic stimulation of the sinoatrial node, producing accelerations that are the hallmark of a reactive NST. Parasympathetic tone, via vagal acetylcholine release, modulates baseline variability and decelerations. Genetic polymorphisms in the beta-2 adrenergic receptor, ADRB2, gene e.g., RS10427113G greater than A, have been linked to altered fetal sympathetic responsiveness, with the AA genotype associated with a 22% reduction in acceleration frequency, P equals 0.03. In placental insufficiency, hypoxia triggers upregulation of hypoxia-inducible factor 1 alpha, HIF1 alpha, leading to increased expression of endothelin 1 and vasoconstriction of fetal arterioles, thereby diminishing oxygen delivery and attenuating HRV. Animal models, sheep, demonstrate that chronic uterine artery ligation reduces fetal HRV by 35% within 48 hours, correlating with a rise in fetal lactate from 1.2 millimoles per liter to 4.5 millimoles per liter, P less than 0.001. Clinical presentation. In the context of fetal monitoring, the clinical presentation refers to the maternal and fetal signs that prompt NST utilization. Classic indications include maternal hypertension, present in 28% of NST-ordered pregnancies, preeclampsia, 12%, diabetes mellitus, 10%, and intrauterine growth restriction, IUGR, 8%. Among these, 85% of women with preeclampsia undergo NST within 24 hours of diagnosis, reflecting guideline recommendations, ACOG 2020. Typical fetal signs captured on NST include key points, accelerations, observed in 92% of uncomplicated pregnancies. Each acceleration greater than or equal to 15 bpm lasting greater than or equal to 15 seconds is considered physiologic. Early decelerations mirror uterine contractions and are present in 68% of term pregnancies. They are benign with a specificity of 94% for normal fetal acid-base status. Late decelerations occur in 14% of high-risk pregnancies, associated with a 5-fold increased risk of neonatal intensive care unit, NICU, admission, RR equals 5.1, 95% CI 4.3 to 6.0. Variable decelerations, abrupt drops greater than or equal to 15 bpm lasting less than 30 seconds, seen in 22% of IUGR cases and predict cord compression with a sensitivity of 71%. Diagnosis. 1. Indication confirmation. Verify high-risk status per ACOG Practice Bulletin 174, 2020, maternal hypertension, diabetes, IUGR, or oligohydramnios. 2. Pre-test preparation. Ensure maternal fasting greater than or equal to 2 hours, bladder empty, and ambient temperature 22 to 24 degrees Celsius to minimize confounding variables. 3. Electrode placement. Apply dual-lead fetal scalp electrodes or external Doppler transducer. Confirm signal quality, 5 MV amplitude, before recording. 4. Baseline recording. Capture a continuous 20-minute tracing. Document baseline FHR, 110 to 160 bpm, variability, plus or minus 5 to 25 bpm, and uterine activity, less than or equal to 5 contractions per 10 minutes. 5. Interpretation of accelerations. Count accelerations meeting greater than or equal to 15 bpm and greater than or equal to 15 seconds criteria. Greater than or equal to 2 such accelerations equals reactive NST. 6. Assessment of decelerations. Classify decelerations, early, variable, late, sinusoidal, using timing relative to contractions and depth/duration thresholds. 7. Adjunctive testing. If NST is non-reactive, proceed to a biophysical profile, BPP, or modified biophysical profile, MBPP. A BPP score greater than or equal to 8/10, or MBPP greater than or equal to 4/5, within 30 minutes supports fetal well-being. 8. Doppler evaluation. Perform umbilical artery, UA, Doppler, a pulsatility index, PI, 95th percentile indicates increased placental resistance and correlates with NST non-reactivity, or equals 3.2. 9. Laboratory correlates. Obtain maternal serum lactate, normal less than 2 millimoles per liter, and fetal scalp blood gas, P. References. 1. Johnson G.J. et al. The equivalence of fetal heart rate variability and accelerations in the interpretation of non-stress tests. American Journal of Perinatology. 2026, PMID, 417076684, https://pubmed.ncbi.nlm.nih.gov/417076684. DOI 10.1055/A2814-9328. 2. Davis-Jones G. et al. Performance Evaluation of Computerized Antepartum Fetal Heart Rate Monitoring, Das Redman Algorithm et Term. Ultrasound in Obstetrics and Gynecology, the official journal of the International Society of Ultrasound in Obstetrics and Gynecology. 2025, 65, 2191-197. PMID 39894929, https://pubmed.ncbi.nlm.nih.gov/39894929. DOI 10.1002/WOG.29167. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.